from the RSNA. Welcome to Radiology Imaging Cancer Journal podcast hosted by the Trainee Editorial Board. I am Yashbir Singh from the Mayo Clinic. We wanted to highlight the ongoing special collection we have. The neuroradiology head and neck collection will be concluding soon, and we will be launching the pancreatic hepatobiliary one next. Dr. Srinivasan is a chief editor for the neuroradiology one, and Dr. Tiwari and Lassie is leading the pancreatic hepatobiliary collection with help from Dr. Luke on the interventional side. Today, we will continue exploring this RSNA theme this year, imaging the individual, with our special guest, Dr. Bonnie Joe. Dr. Bonnie Joe is inaugural Edward A. Sickles Distinguished Professor in Radiology and Associate Chair of MD Faculty Mentoring in the Department of Radiology and Biomedical Imaging at the University of California at San Francisco. She previously served as a division chair of breast imaging at UCSF for 17 plus years, is a past fellowship director and has 22 plus years of experience teaching and mentoring trainees of all level including radiology fellows. With a foundational PhD in electrical and computer engineering and decades of hands-on breast imaging leadership, she blends engineering rigor with the patient-centered care. Her research spans advanced screening strategies for dense breast MRI, AI deployment in mammography, and registry works through the San Francisco Mammography Registry and BCSC. She serves as a deputy editor for radiology imaging cancer, and also she is on the board of trustees for the RSNA Research and Education Foundation and board of directors for the Society of Breast Imaging. She has led transformative clinical workflow at UCSF and taught resident and fellows and engaged in the policy and equity issues in the breast cancer screening. Dr. Joe, welcome to the show. You did a PhD in electrical and computer engineering. What engineering habit still shapes how you read breast images?
I don't think I've ever been asked that question before. But yes, I think my engineering background has given me a very systematic approach to radiology in general. So whenever I read images, I try to follow a specific search pattern, especially if you're reading a screening mammogram, because that's the best way to make sure you don't miss cancer and you don't get distracted by things. The other thing that engineering training has taught me, I think, is just a very analytical approach. And I teach this to the residents too. Radiology, it's best not to do that shoot from the hip, gestalt approach. It's really best to take a step back and analyze the images, try to understand the image quality and then the question that is being asked and looking for any abnormalities, recognizing normals. So, engineering training, I think, is just a really great way to approach life, even. It's something that appeals to my analytical brain. So, it's hard to know, like, whether I chose engineering because I like analytical thinking or whether that's what actually even led me into radiology as a career.
So, what first drew you to best breast imaging and what keeps you passionate about it today?
So I should tell everyone, and those who knew me at the beginning of my career recognize that I started my career in body MRI. So my original intent was to become an MRI imaging expert, and I was reading primarily cases like liver and pancreas and kidney stuff. When I joined UCSF, I was in the abdominal imaging division. But at some point early in my career, the chair at that time, Dr. Ron Aronson, really needed help in breast imaging. And because I was doing breast MRI research, he thought I would be someone who was approachable or moldable to become a breast imager. little did I realize at the time, they actually not only wanted me to join the breast imaging division, they wanted me to be the chief of the division. So I should say I kind of got pushed into that role, but it has really turned into a great opportunity. I had a leadership opportunity with it, but also I am passionate about breast imaging. It is a career that allows me to help women and patients deal with breast cancer. It's about early detection. It's very patient centric and very patient facing. So, those aspects of being able to see patients every day and help them through a difficult journey sometimes is really a lot of fun. It's a great way to be a doctor.
And that passion is very important right now because breast screening is everywhere in the news. The US Preventive Services Task Force recently reaffirmed screening starting at 40, but every 1 to 2 years is still debated. From your perspective, what should radiologists actually recommend today?
I hope, and actually, I'm really glad that the task force is now aligned with most major cancer organizations by saying screening should start at age 40 for everyone at average risk. We recommend, and this is per the American College of Radiology guidelines, the Society of Breast Imaging guidelines, the NCCN guidelines. We all recommend starting screening at age 40 and going every year. So annual screening at age 40 and no upper age cutoff. Really, if a patient is healthy and expects to live 5 to 10 years, that person should continue to screen because early detection will prolong their life. They will not die early of a breast cancer unnecessarily. I should point out that people who are at higher risk, for example, those who have genetic mutations like BRCA is the most famous one, but there are actually many genetic mutations that carry an increased risk for breast cancer. Those people should screen earlier, and those people should also be getting breast MRI screening annually. We recommend that everybody have a risk assessment, especially cisgender women, before age 25. You need to know your risk because 25 is when we actually recommend starting breast MRI screening. So there's a lot of education to be done still, but I think that it's good that screening is in the news because hopefully this gets the information out to the public. But at minimum, I do teach all of my residents that they should be recommending screening annually at age 40 for all comers.
So, how do you reconcile the differing voice and specialty societies when patients ask you directly, like, what's your message to the women confused by these headlines?
I admit it is confusing. For example, in the US, like in the United States, we have three major guidelines. One from the American Cancer Society is what we call a hybrid guideline because they recommend starting at age 45 annually and then they switch to biannually every 2 years at age 55. The task force used to recommend 50 as a starting age, which was way too late, in my opinion. But now they say 40, except they say every other year. And then at 74, they actually don't have a formal recommendation. And then, as I mentioned, the SBI, Society of Breast Imaging, American College of Radiology, and the NCCN, those societies that specialize in cancer care and imaging recommend annually at age 40 without an upper age limit. What I tell patients is that it is always a personal choice, but a way to think about this is how you feel about early detection. If you want the best chance at detecting a breast cancer early, common sense would dictate that if you get your mammogram every year instead of every other year, that would give you a better chance. Waiting every 2 years means that potentially a cancer could grow for 2 years before it's detectable. So, taking a common sense reasoning approach to it, that if it's not too much trouble for you to get a mammogram, and these days, screening mammography is covered for everybody starting age 40. It should be covered annually. That is mandated by Congress, and we hope to maintain that mandate. That's really where the risk benefit discussion is. The reason different governing bodies have differing guidelines, it's really about where they put their emphasis, whether it's on cost or if they are overemphasizing what they call the false positives, meaning the chances that a patient may need to come back for more studies or even a biopsy. What I tell patients again here is a false positive is the medical definition when you get a screening mammogram and say there's an abnormality. A lot of times it's just a little spot that is unclear whether that really is something significant or not. For example, we call it an asymmetry. When they come back, they're really just getting additional mammographic pictures or getting a breast ultrasound. And then most of the time, it is resolved as benign or reassuring, and this would be termed a false positive. So it is how screening is designed. We design it to have a low threshold. We want to pick up anything that seems possibly suspicious. They come back for part two of the exam, as I call it, which is a diagnostic appointment. And then at that point, we talk to them. They get to know right away what the results are. And then for the 1% of people that might need a breast biopsy, that's also an outpatient procedure. It's very well tolerated. It's what we call a minimally invasive procedure. It's just a needle biopsy with some numbing medicine. So it's nothing major. The medium sometimes makes it sound like we're telling patients they have breast cancer, right? Every time there's an abnormal screening exam, and that's not the case. So I think that for the most part, once you educate the patients, they understand the differing guidelines, and then they make the best choice for them. And I'll tell you, most people would want to have early detection and are not so concerned about having to come back for some extra testing.
So for women with the dense breast but no other major risk factor, what's your real world algorithm, and when do you reach for ultrasound, contrast enhanced mammography, or MRI? Just I want to know your opinion in your practice at UCSF.
Thank you for that. And yes, acknowledging this is a question for which there is no pure right or wrong answer. A lot of different practices will offer different things. The concept of dense breast tissue is that on a mammogram, it's tissue that looks white. And then because cancer is also white, then your concern is with density, you might mask a tumor. It's harder to detect a tumor. It doesn't mean that you cannot detect tumors on in the dense breast patients. So first off, I want to emphasize for everyone that mammography is the tried and true test. It's been proven in randomized controlled trials and also scores of population-based studies. It works. So mammography everyone should be having for screening. Then the question is if you have dense tissue in the United States, that's defined as heterogeneously dense or extremely dense breasts, it's about half the population, then you get a letter that tells you you're dense, and you may have an option to choose additional what we call supplemental screening. And you mentioned the three big ones, which is breast ultrasound screening, contrast enhanced mammography, or contrast enhanced MRI. At UCSF, if patients are questioning what to do next, we always ask them to get a formal risk assessment because if they're high risk, and that's defined as greater than 20% lifetime risk, they should be getting annual breast MRI in addition to annual mammography. So this would be alternating every 6 months. They would get like a mammogram in January, and then in June, they'd get their MRI, for example. If they don't have any particular risk factors other than breast density, if that's the only concern, then we offer contrast enhanced mammography. This is another what we call vascular imaging technique. So, the vascular imaging modalities, which are the contrast enhanced mammography or the contrast enhanced MRI, have been shown by studies to be the most sensitive. Ultrasound is also performed and is an option, but we don't offer it at UCSF because the sensitivity is significantly lower than the vascular imaging tests. So for us, I would usually steer a woman towards a contrast enhanced MRI if she's high risk, and then if not, we would offer contrast mammography. But I acknowledge this is going to differ by practice. I think at the end of the day, As long as the patient's in a practice that does whatever they're doing well and can follow up on on the abnormalities, then that's most important. Because you don't wanna be caught in a situation where you have an abnormality and then you have to go hunting for somewhere to do the follow-up.
So, yeah, definitely technology cannot move faster than access, and that leads us straight to equity. You also practice at Safety Net Hospital in San Francisco General Hospital. So, from that vantage point, what is the biggest flexible inequity in breast screening today?
Sure. I think having the advantage of practicing at a university practice that's well resourced and also practicing at the general, which is our safety net hospital, and very under resourced, gives me that viewpoint of seeing what disparities exist even in the city and county of San Francisco. So, one problem that I see on a daily basis is the relative underutilization of even just screening mammography in our safety net hospital. We are still working on this. We continue to work on this. It is fixable. I think first off is educating all the clinicians, getting it on their radar to remind all the patients to get screened, and then the other issue is getting the patients to actually schedule and show up for their appointments. So it is in theory fixable because we have the technology, we have the appointments, but in practice, there are clearly other factors at play, and some of them are simply things like, trouble with getting childcare or trouble getting time off work, or just a lot of competing demands on this patient population so that they don't prioritize their own screening. One thing we do at the county that is helpful is bringing a mammo van to the clinics. Currently, our van is going to various clinics on a pre-scheduled basis, and the idea here is that the patients literally see their primary doctor for their appointment, and then they are literally walked outside to go get their screening mammogram. So that has helped, but I think there are the issues of access and resolving those inequities. I recognize it's a bigger problem than simply creating the access or having the technology available. So, it's something we continue to work on, and I encourage others to also continue to work in this space. I definitely feel that this gap still exists even in my own practice, and, I don't know that I have an easy answer on how to fix it, but we keep trying. Okay.
So, do you think AI could help or worsen disparity?
So, very exciting is that we recently, did a research study at the county hospital and using an AI tool. So this is the work of Dr. Maggie Chung and also in collaboration with Dr. Adam Yala, who's at UC Berkeley. So the AI algorithm would be run on the images. So it's a pixel-based algorithm. So the 4 images from a screening mammogram would be run through the AI algorithm, and the cases that were at high risk of being recalled, like the most likely to recall this case scenario, those patients would be approached and asked if they would like to consent to participate in this research study. We actually consented them ahead of time, and then if they got flagged, they would be offered a same-day diagnostic appointment and even same-day biopsy if it could be accommodated. So by doing this, we were hoping to shorten their time from screen detected abnormality to ultimate diagnosis, and the study was pretty significantly showing AI improved that time because in the standard of care scenario, you have a screening abnormality, the patient gets contacted, they get scheduled for an appointment. This could be, 1 to 2 weeks later. They might miss the appointment or not show up, and then they're contacted again, and then, they may or may not show up for their biopsy appointment. You kinda get the picture where it could be a very protracted course to get to the end of the to get to the end of the care. And with this AI tool flagging high risk cases, patients were getting same day workups and some cancers were diagnosed right away. So, this is going to hopefully be published soon. It's been submitted for consideration. We'll see how the reviewers like it or don't like it. And hopefully, it'll be published and be available soon in PubMed. But it is actually on a preprint server right now if anyone is interested in the results. But I think in this case, AI definitely can help with the disparities. It actually can help for all comers, not necessarily in a safety net hospital. It can help expedite care. But in our safety net hospital in particular, this is why we wanted to run the study there, is that's where we felt there was the most need. So this is an application of AI that I think is impactful and low risk in the setting that in the sense that I think you can only do good in this scenario. It's sort of like a triage algorithm.
So, before we wrap up, I would like to end on a more personal and visionary note. If you had $100 million to invest in the next frontier of the breast imaging, where would you put it?
Boy, yes, that would be a dream come true to have $100 million at my disposal. I would say for me, I don't know that I could necessarily predict what the next frontier of breast imaging will be. However, I want to let you know I am a trustee for the RNE Foundation, and the grants programs is a wonderful program that seeds very new ideas and also helps develop our future generation of academic radiologists and also this is what I believe will be our future practice. So I think all those smart people that have received grants and that apply for our grants, they deserve as much support as we can give them, especially in the current climate of funding. So I would likely personally put all of that into the R&E Foundation program. And this gives me a wonderful opportunity to plug the grants program. So I believe in our program notes, we will have information on how to donate. I encourage you to donate to the R&E Foundation. I've personally benefited from it as a grantee a long time ago. And it is just a wonderful way to support the future of our specialty. And these are really great, young, exciting people. I mean, the future is bright, and I feel very comforted by the fact that we have all these wonderfully smart young investigators who are interested and passionate in this topic. And I always joke, these are the people who are going to take care of me one day, right? So please do check out that link, and you feel like giving back. It is good for our specialty.
So nowadays, like as we, I mean, like I know that residency interviews are going on. So, what advice do you give a first year resident reading their very first mammogram?
So we routinely get first year residents now rotating through breast imaging service, which is wonderful. So we can introduce them to our specialty early. I usually just tell them to take a deep breath and don't worry because a mammogram is tough. Like breast tissue doesn't have a lot of defined anatomy. And the best thing is to just kinda come along for the ride. So we go through a systematic approach. I share my own approach of how to systematically read a mammogram, but beyond that, my goal for anyone new to the service is just to get a flavor of, what is breast imaging, and a lot of what we do is multidisciplinary, talking to clinicians and talking to patients, so just getting that sense of how do you be a good breast imaging doctor? Actually, not just a good one, but an amazing one, and be supportive to your team and interact. So if they just come in and get that sense, absorb, feel the ambiance, that's really my goals for a first year resident. And then the ability to read and detect things that comes with time, right? Everyone will learn that eventually. It just comes with practice.
Thank you. So, and anything would you like to share?
I think you covered a lot of a lot of ground in these questions. So once again, please check out the link for the R&E Foundation grants programs. It's never too late to donate, share with your friends, and the foundation thanks you.
Thank you, Dr. Joe.
Thank you so much.
Thanks for spending time with us today. Special thanks to our guest, Dr. Joe, for her valuable insights. If you are enjoying the conversation, please rate, review, and subscribe wherever you are listening. Your interactions helps more listeners find the show. Check out Radiology Imaging Cancer. Link to the journal will be in the show notes. Today, you heard from our team. Special thanks to our editor, Kelly Myers. We will see you next time on the Radiology Imaging Cancer podcast.